today Dr. Touchette, who has a BS in pharmacy from the University of Manitoba, master's in PharmD from Wayne State in Detroit, also did a fellowship there at Wayne State in pharmacoeconomics. He is the Takeda Professor of Medication Adherence, even though he is not wearing his medal today. And he is going to talk about their ICER work with respect to the new drugs in tardive dyskinesia. So special thanks for him pitch hitting and late notice.
All right, thanks. Well, thank you. I thought I was actually volunteering Suri to give this talk. And I said, no problem. One of us would be able to do it. And then Suri said, I'm not going to be here on that day. So, all right. So today I'm going to be talking to you about cost effectiveness of VMAT2 inhibitors for tardive dyskinesia. As you may or may not know, with these ICER projects, there's a very quick timeline, and there are a lot of collaborators involved in this. The systematic review, I have the collaborators who are involved in running the systematic review, and then the economic model on the right-hand side, which from UIC included Suri Walton, Kate Harrigan, and Shirley Wong, who is a P2 student who's been working with us. P2, right? P3 student who's been working with us. So I had a video playing and was hoping to have audio to it when you walked in that showed a sort of a typical case of tardive dyskinesia. And I wanted to sort of point out what some of the issues were with tardive dyskinesia, because it really helps in understanding the impact that this condition can have on patients. I can give you sort of the medical background. It's a repetitive involuntary movement disorder with a delayed onset. It's caused by the prolonged use of dopamine receptor blocking agents typically, although one of the women that I had in the video got it from just a single course of therapy with a dopamine agent in an emergency department. She received metoclopramide, and it's a permanent condition for her. There's an estimated 500,000 individuals with TD in the U.S., and until recently there were no FDA-approved therapies to treat tardive dyskinesia. I just want to step back a bit. One of the most common causes of tardive dyskinesia are antipsychotic drugs. And we thought that we had tardive dyskinesia solved in around 1995 when the first second-generation antipsychotic agent came out, and there was no tardive dyskinesia observed in the clinical trials. But what we found is with prolonged use of second-generation agents, tardive dyskinesia does occur as well, just at a slightly lower rate, and it might be a little bit more delayed in onset. So unfortunately, we're treating people for longer with these drugs. We think they're safer, but a significant number of people develop TD with these drugs as well. So these drugs are very expensive. We're going to get into how expensive and what that means. But to sort of develop some of the background for why this work is really important, what we see here in commercial plans, and the two new drugs are valbenazine and deutetrabenazine. These are the two FDA-approved drugs. We're seeing that in commercial plans, only 23% are covering these agents. 100% of those are in the highest tier, and they require prior authorization before use. In New England Medicaid programs, what we're seeing is that 0% of the time these drugs are on the preferred drug list, and 100% of the time they require a prior authorization. So we're seeing that there isn't great uptake of these drugs, and we're going to be describing a little bit about why. So in the systematic review of literature, which is done prior to or concurrent with, but mostly prior to the model, the cost effectiveness model that we develop for this drug, these were the three for these therapies. These are the three therapies that we were going to be looking at for VMAT2 inhibitors. Valbenazine, brand name Ingrezza, and deutetrabenazine, brand name Austedo, were the two new drugs coming to market. And then there was an older drug called tetrabenazine that was approved for Huntington's chorea and had some off-label use It's been around since 2008, so almost 10 years, and had some very minimal amount of use for treatment of patients with tardive dyskinesia. Some of the issues with tetrabenazine is that there was a black box warning for suicidal ideality. There's a suicidal ideation rather, it's because a lot of patients who develop tardive dyskinesia have some component of depression. There was a lot of concern in using tetrabenazine in this patient population. The scope of the systematic review was to compare the clinical effectiveness of VMAT2 inhibitors for the treatment of tardive dyskinesia due to dopamine receptor blocking agents. And the inclusion criteria were all relevant clinical trials, including non-comparative study designs, knowing that we might not find a lot of information on tetrabenazine, at least, except in non-comparative studies. Adults 18 or older, symptoms for at least 3 months, and a history of DRBAs, and minimum sample size of 10 patients. The effectiveness outcomes we were interested in were primarily these rating scales, and I'm going to show you what these rating scales cover, but the AIMS was the primary one. It's the Abnormal Involuntary Movement Scale, and then the Clinical Global Impression scale, and there's a patient-rated and a clinician-rated version of these. And again, I'll show you them in a second. And then for safety outcomes, we were interested in adverse drug events related to these therapies. So this is the AIMS. There's 14 items, and they're all graded using a 5-point Likert scale from 0 to 4. And what it does is it grades each sort of region of the body or each area of the body separately. So for facial and oral movements, it asks about abnormal movements in the muscles of facial expression, lips and perioral area, jaw and tongue. For extremity, it's upper and lower, and then trunk movements, global judgment, and dental status. There's other sub-questions for those as well. For the Clinical Global Impression Scale, it basically assesses the severity of illness and global improvement on a 0 to 7-point Likert scale, so 8 points total. And this is what the piece dealing with the side effects looks like. It's kind of a grid, and it's hard to see because this is in the way. Move it out of the way. But what we have is marked therapeutic effect, moderate therapeutic effect, and minimal therapeutic effect. And then the side effects, there's no side effects, does not significantly interfere with patient's functioning, significantly interferes with patient functioning, and outweighs therapeutic effect. So on this grid, clinicians would circle whichever one is appropriate, and then you can evaluate later on if there's any change in the global impression scale at a later date. Come on. I may have also, oh, there we go. Okay. So just to sort of summarize this, because this presentation is not about the systematic review that was done. Here are the outcomes from the systematic review for valbenazine. What we saw for the AIMS scale was a greater reduction in AIMS scores and more patients with 50% or greater improvement in the AIMS score compared with placebo. It did not demonstrate a consistent benefit over placebo in the Clinical Global Impression scale, and did not demonstrate a consistent benefit for the patient evaluated Global Impression scale. For deutetrabenazine, again, we saw an improvement in the AIMS score, and no benefit in CGIC and no benefit in PGIC. So they were fairly consistent in their effects. I think the key word here is for valbenazine, it didn't demonstrate a consistent benefit. Deutetrabenazine showed no benefit in either of these two scales. And that word is important in there. Other benefits or considerations, because ICER likes to put everything in context as much as possible, is that VMAT2 inhibitors are the first FDA-approved therapies for TD. So that's an important consideration when we're considering how much we should be paying for these therapies. They can potentially improve control of underlying psychiatric conditions. And this is more of a hypothesized benefit or consideration. And it's thought that, or at least hypothesized mainly by the pharmaceutical companies who produce these drugs, that there could be improved adherence to antipsychotics, which then there would be other benefits to therapy with these. VMAT2 inhibitors could facilitate TD patients' ability to work, and that really depends on the population that we're evaluating. If we're evaluating poorly controlled schizophrenic patients, it's unlikely that they would return to work. If we're evaluating patients with mild illness, or one of the women that I had when you walked in the room up on the screen, it's quite possible that she could be working and that these movement disorders could impact her ability to work. So it really depends on the population. We found very little information about these things in the literature, which made it hard to evaluate the potential benefits of therapy or whether they benefited it at all. Also, VMAT2 inhibitors could decrease caregiver or family burden. That was another hypothesis that was brought up by the pharmaceutical companies. Again, very little data to support those things. So before I move on, does anyone have questions about TD or? All right, so we'll move on then to looking at the cost effectiveness piece. So the objective of our analysis was to estimate the incremental cost effectiveness of treating symptoms of tardive dyskinesia with valbenazine and deutetrabenazine compared with placebo as a proxy for no treatment in a representative population of U.S. adults aged 18 and older with underlying conditions of schizophrenia, schizoaffective disorders, and affective disorders. We included affective disorders because an increasing number of patients with bipolar disorder or severe intractable depression are being treated with antipsychotic agents as well, and so they're at risk for developing tardive dyskinesia. The methods that we used a semi-Markov model with time-dependent mortality rates. Who here can tell me what a semi-Markov model is? Anyone? Oh, come on. All right. Brian? Oh, your mouth is full? All right. So a semi-Markov model allows the probabilities of transitioning from one state to a different state to vary over time. So it's perhaps a little more realistic model than what you would typically think of with a Markov model. So we have time-dependent changes to those probabilities in our model. And you might think of things like mortality rate. The probability of dying in a year changes over time. And that's one of the things that makes this a semi-Markov model. The setting is the United States. We're taking the payer's perspective, which is direct medical care and drug costs. We do a couple of sensitivity analyses, which I'll describe, that gets a little bit more into a societal type setting, but not a comprehensive societal setting. We took a lifetime time horizon because that's ICER's policy. They always do things from a lifetime perspective. And a discount rate of 3% per year, which has become more standard. Cycle length of 1 year. And we evaluated costs and quality adjusted life years, and the primary outcome was a combination of the two, cost per quality gained. The patient population that we included is the adult US population aged 18 to 64 because that's where we could find the most relevant data for this, even though this condition can affect people older than 64. It was difficult to find information in that patient population. The underlying conditions were schizophrenia and schizoaffective disorder and bipolar disorder. Patients with schizophrenia and schizoaffective disorder, their mean age was 38 years. 52.5% were female, and it represented about 70.2% of the model population. Affective disorder, mean age was 40 years. 64.8% were female, and this represented the remaining population that was modeled. So here are some of the parameters we defined valbenazine and deutetrabenazine dosing. Valbenazine was 80 milligrams. It was available as an 80 milligram capsule. This is important for the pricing piece of all of this. Oral route and duration until discontinuation or death. So people would take this drug indefinitely in the model. Deutetrabenazine was a 36 milligram dose, which is a little bit less than the maximal recommended dose, which is 48 milligrams. But this was the dose that was commonly used this is the dose that was settled on average in the clinical trials. So not everyone was able to tolerate the 48 milligram dose, and so this was the mean dose from the clinical trials. So we decided to use this. The rationale for using the maximum dose is that in clinical practice, patients are titrated to the maximum medication effectiveness without intolerable side effects. That was sort of the premise behind it. Some of these drugs need to be titrated up. And because people may get just a little bit more benefit from a higher dose, clinicians would titrate the dose up until they received maximal benefit, and then they probably wouldn't back down on the dose later on. So we assumed that people would be receiving the maximal dose. We had a ton of assumptions in the model, and this is one of the interesting things about tardive dyskinesia. We knew that it might be difficult to find some of the model inputs in this model, but we didn't realize how difficult it would be. All research on tardive dyskinesia pretty much stopped around 1995, when we had these new agents that everyone thought would reduce the risk of developing tardive dyskinesia. And a lot of the cost effectiveness models dating back to that time are focusing on the fact that tardive dyskinesia doesn't develop with these drugs, and then the benefits that are associated with that. But what we're finding is that a significant number of patients are still developing TD on these drugs. So we just didn't have a lot of current data to work with. The data was mostly 20 years old. And then started picking up, some of the research started picking up in the last 3 or 4 years. So we had a few more recent estimates. So these assumptions are that patient response to treatment is reflected in their initial health state. I'll explain what this means in a second when I show you the model. The second one is that patients not responding to treatment with valbenazine or deutetrabenazine discontinue their treatment in the first month and enter the model with moderate to severe TD. This just basically says if they don't get benefit, they stop taking or if they don't get enough benefit, they stop taking the drug. We didn't want to penalize patients in the model with incurring costs, this high cost of this drug, if there was no benefit from it. Response to treatment remains constant for all responders thereafter unless they subsequently discontinue therapy. So reasons to discontinue therapy are lack of effect or presence of a side effect. But for those who received some effect and had no side effects, they would continue taking the drug indefinitely in our model. Long-term discontinuation rates were modeled from open-labeled studies with less than 1 year of observation. These are brand new drugs. We have no information about how people take the drugs for a long, long time. But we have to make these assumptions because it's a lifetime model. Patients not responding to treatment were assumed to have 2 additional primary care and 2 additional neurologist visits per year. This was one of those scenarios where we had no information at all about the cost of treating tardive dyskinesia. Nothing even before 95 addressed the costs of treating tardive dyskinesia. So we made what we thought was a rational argument for what care might be for these patients, but we were just guessing. And we had to put something in the model, though. TD treatments do not have a direct effect on mortality. They're not demonstrated to, so it's not so much an assumption as we're just extrapolating what we know. And for the base case, treatment of TD has no effect on the outcomes or costs of treating the underlying conditions. This is for the base case, but like I said, we ran some scenario analyses around what if tardive dyskinesia treatment of TD actually resulted in better treatment of schizophrenia, because patients are able to stay on the same drugs even though those drugs were the ones that caused TD. So we ran some scenario analyses around that. I hope you can see these models. We have a treatment and a placebo model. For the treatment model, there's 4 states. For the placebo model, we only had 3 states. People who benefited from treatment started in the improved tardive dyskinesia state. That was about 30% of patients who took the drug. The rest went to moderate to severe tardive dyskinesia, and after the trial run of the therapy, they were no longer taking the drug. Okay, they didn't get benefit. They no longer took the drug. There's no costs incurred for taking the drug, but they also received no benefit. For those who had improved tardive dyskinesia, over time, they might discontinue therapy and move back to a moderate to severe tardive dyskinesia state. There's also a strong placebo response, and we don't know whether it was placebo response or the natural course of the disease. It's not a static disease where you develop these symptoms and next month the symptoms are exactly the same severity. It fluctuates over time, has a lot to do with stress, other factors in patients' lives. And so we had no information about the clinical course of therapy off of treatment. Those studies just didn't exist. So the strong placebo response was partially embedded in those who improved on drug, and then those who just had a placebo response. So those who improved because they were on drug when they discontinued, we made them move back to moderate to severe TD. Once the drug is stopped, they don't get the benefit of the drug. Their TD comes back as bad as it was before. For those whose natural course of the condition gradually gets better over time, taking the drug, it might look like they improved. But over time, if they have a side effect with the drug or they have to discontinue the drug, they stop the drug and they still have improved TD because it was part of the placebo response or part of the natural disease course. For the placebo model, we handled it the same. People either had some placebo response, which they retained forever, or they stayed in moderate to severe dyskinesia. So this state here is the same as this state down here, plus some of the people who remain treated, right? They have that placebo response, they remain treated. We don't know that the therapy isn't the reason for it, but they have a better clinical course. So that was a tricky part of this, was making sure the 2 groups were equal, but that's how we handled it. And then throughout the model, patients could die of natural causes. There is a higher mortality rate for patients with schizophrenia and bipolar disease. We built that into the model as well. So this just describes what the transitions and what I just described. So I'm going to skip that slide. How we handled adverse events in this model, you can see that we didn't really address adverse events in the model. These drugs were actually extremely well tolerated by those who tolerated them. There were no sort of bothersome side effects that continued. There was nothing that needed, subsequent treatment to manage a side effect or something like that. So there were no severe adverse events noted in the clinical trials, but the discontinuation rates were different between the placebo and the active drugs. So we built that discontinuation rate into the model, and we also varied it. But the discontinuation was assumed to be because of minor adverse events, bothersome adverse events that would lead to people stopping taking the drug. And so the model reflects differential discontinuation rates, but no other adverse events were built into the model. Here are the key model inputs. We have the proportion of placebo responders with a greater than 50% reduction in the AIM score, the treatment responders with a 50% reduction in the AIM score, and the annual discontinuation rate in the first year. You can see it was a pretty high discontinuation rate, 17.6%. You can see 40% for valbenazine and 33% for deutetrabenazine responded to therapy. You can see a high either placebo response or natural course of the clinical condition. We don't know what is going on there, but people improved on placebo over time. Here's the price of the drugs, and this is the main issue that we are dealing with. Now, we often see prices like $75,000 a year for oncology agents and other things that might be curative. We seldom see it for chronic, well, we don't ever see it for chronic conditions. So even with discounts, 27% average discount, we're talking $55,000 a year for valbenazine and almost $66,000 a year for deutetrabenazine. When you think that these patients are going to be treated lifetime or as long as they tolerate the drug, these are huge, huge amounts of money. So this is why health plans are struggling with covering these drugs. These drugs were originally approved for Huntington's disease, which is an orphan. They received orphan drug status. It's a small population of patients, and often companies are willing to pay higher prices for drugs that are developed for that have orphan drug status, orphan conditions. But with 500,000 patients per year, and it seems to be increasing considerably every year, 500,000 patients with TD in the U.S. every year. These are not small numbers anymore, and they're pricing it the same as they did for Huntington's disease. The utility was another piece that we had to struggle with a lot for this. If you noticed, it was earlier on, it was a 50% improvement in the Ames score. That was the measure of clinical benefit for this. Not a complete elimination of TD symptoms. And if we think about moderate to severe TD, I wish we had been able to hear these patients talk at the beginning if we had had sound, because in the videos you can see how much TD can affect patients. Now, I don't know what a 50% reduction in the Ames score actually means for these patients, and no one there could really explain what it meant in real terms. It meant that on grading it, that whoever was doing the grading, they were watching videos of the patient's movements. The movements declined or slowed or changed by 50%. But what does that mean for someone who can't get a job because they have these abnormal movements? Does that mean that they can go back to work? We really don't know. And there's I think those studies are starting to be initiated, but it was difficult. So in trying to determine what utility to value or utility benefit to value these therapies, it became very difficult. But what we were able to find, the modeled population, patients with schizophrenia and bipolar disorder, there are a lot of estimates for the utility for those patients. Those are common conditions. They're well evaluated. Schizophrenia, in almost every paper we looked at, was about a utility value of 0.83, and bipolar about 0.8. When we multiplied those two by the proportion of patients in our model, we get a base case value of 0.82 in the model. So this is people with no TD, but they have the underlying conditions. The utility decrement from moderate to severe TD, we found one paper and it was a very old paper done in non-TD patients with a value of 0.095, and then a couple of other hypothesized estimates. So we applied this decrement. It was the best value we could find. We applied this decrement to TD, or decrement in utility for having TD, meaning that patients with TD would have 0.82 minus 0.095. That would be their utility value. So about 0.73-ish. We gave everybody in the model who was successfully treated with these drugs the full decrement back. They got the full 0.095 back, meaning that they didn't have a utility decrement for having half of their TD symptoms anymore. We knew that this wasn't going to be cost effective, so we tried to give them as much benefit as we could. And so we gave them the full benefit. It still became a point of contention, but it is what it is. Here are the model base case results. So after plugging all of this in and running it lifetime, we see the total costs for those who receive valbenazine was just under $190,000 a year, or lifetime. Placebo was $6,876. Deutetrabenazine was $220,000 over the course of the lifetime, and placebo similar to the valbenazine group. We modeled each of these separately. We didn't compare them to each other because we didn't have enough data We couldn't do a network meta-analysis. We couldn't do anything that would compare these two to each other. So we just looked at each individually. Total QALYs was 15.35 in the valbenazine group and 15.12 in placebo, 15.37 in deutetrabenazine, 15.18 in placebo for the deutetrabenazine group. So we see a difference of about 0.23 quality-adjusted life years gained over the lifetime of a patient, which seems like a small number, but it's actually quite large. This is one of the bigger effects that I've seen from therapies. Again, we're giving them the benefit of fully curing TD when they're actually only reducing symptoms by 50% or more. But this is actually a pretty decent utility gain or quality gain. Here are the cost effectiveness ratios. So here's the incremental costs. There are the differences in the costs, the differences in the QALYs, and the ICERs. 752,000 and 1.1 million per QALY gained. And for those of you who have been working in this area, you know that anywhere between $50,000 and $150,000 per QALY gained is kind of the acceptable range of the cutoff for willingness to pay. And so these are 10 times, or about 10 times that in each case. We also did some other analyses just because it's sort of standard to do this. So we did something called a cost per TD symptom reduced year for people who hate QALYs, which is anyone who didn't like the values that came out from the QALYs. And what we saw was kind of the same thing. It's hard to evaluate what these numbers actually mean because I don't know how much I'm willing to pay for a TD symptom reduced year. But it was just another way of crunching the numbers and coming up with something. Sensitivity analyses really did nothing. You can see most of them are blips here around, this is for valbenazine, around the 700,000+ per QALY gained. The two that did have a significant influence on our estimate was the disutility with TD. We varied this tremendously from 0.19 to 0.0475. 0.19 is a huge utility decrement or benefit for a drug. We used extreme values for this because we were so uncertain what the true estimate should be. At the low end, it was still about 390,000 per QALY gain, still well over the estimate. The cost of valbenazine, same thing, we varied it all the way down to $27,000 a year, which was half of the discounted price, and still at 390,000-ish per QALY gained. So in short, for the sensitivity analyses, none of the sensitivity analyses or scenario analyses resulted in an ICER below a ratio of 150,000 per QALY gained, which is probably at the top of our willingness to pay level. We did some other analyses just to see what effect they would have. This one here is showing the effect of varying the utility decrement for TD along with the proportion who had a 50% reduction in the AIM score. So we didn't know what benefit 50% reduction in the AIM score would have on utility. So this kind of makes sense. And even at the best estimates, so 60% of people having a 50% reduction in their AIM score and a utility decrement of 0.15, we're still up over the $400,000 per QALY gained mark. So every benefit we could possibly give these drugs, it resulted in ICERs that were well above our common thresholds. Here's the same thing for deutetrabenazine, and that one didn't reach 500,000 per QALY gained with all the benefits we could possibly give it. We also looked at a threshold analysis. This was varying the cost of valbenazine and deutetrabenazine to see at what cost. And remember, this is still giving that maximal utility benefit from our base case. But given that benefit, what cost do these drugs need to be per year to be cost effective? And At the 150,000 per quality gained, which is again the upper threshold of what we would normally consider cost effective, these drugs need to be $9,000 to $11,000, around $10,000 a year. If we have a lower threshold of 100,000 per quality gained, they need to be closer to the $7,000 range per year to be cost effective. Then we did probabilistic sensitivity analysis just for completeness. And these are the inputs that we included in the model. I won't go through this too much because you can see it really didn't have much of an effect under all of these scenarios. Even, I mean, this one for valbenazine never even approaches the 150,000 per quality gained. You know that some of these runs might be picking the best scenarios possible for these drugs. We did this 1,000 times, so probably one or two of these are picking some very favorable estimates from what we put in. Doesn't approach the threshold. There were a few for deutetrabenazine where because of greater variability in our estimates, we started to see some that might approach the line down here, but it wasn't. Most are well above. The scenario analysis that we built, that I've alluded to a couple of times, we added a couple more states, and those states were improved TD with the underlying condition controlled. That's the bipolar disease or schizophrenia, better controlled. Again, following the hypothesis that treating the TD will lead to patients taking their schizophrenia medications more frequently, or being able to stay on the same medication on which they were controlled but develop TD. And then no treatment, improved TD, underlying condition controlled was another option added here. And in the placebo group, improved TD, underlying condition controlled. And then up here, not controlled, and this is not controlled. So we've added in this concept that schizophrenia might become uncontrolled in some situations, and that patients with better TD, it happens less frequently. We added a whole bunch of new parameters to the model. Proportion of patients with TD becoming non-adherent to antipsychotics. We had no idea what this estimate was. It's completely hypothesized. So we put in 10%, believing, at an upper limit that 10% of patients might become non-adherent to their medication, their antipsychotic medication, because of their TD getting worse, that they may stop taking their antipsychotic medication, and that if you treat the TD, that this wouldn't happen. And then costs for well and poorly controlled schizophrenia, bipolar disease, productivity losses for another scenario analysis. That's not for this one. But we wanted to build in, what if people could go back to work? That was a second scenario analysis we did. Disutility resulting from poorly controlled schizophrenia, schizoaffective disorder, and disutility resulting from poorly controlled bipolar disorder. So big decrements for people who had poorly controlled schizophrenia versus well-controlled schizophrenia. As you can imagine, it has such a huge effect on patients' lives. And here are the costs per quality gained in these different scenarios. So if we included productivity, it really had no impact. The reality is that patients with schizophrenia and bipolar disease, for the proportion of patients who can work, they often work in lower paying positions. And this type of an analysis, this is sort of what Steve was alluding to as well in his talk a couple weeks ago, was that building in productivity gains sometimes can be a little bit ethically challenging. What do you put in for someone's productivity? We used actual values for patients who have schizophrenia that's well controlled and are working, which was about $18,000 a year. Very low earning positions on average. So it had, including productivity, had little impact on the ICER. When we looked at hypothesized effects on schizophrenia and bipolar disorder, again, hypothesized effects, we see that the cost per quality, the incremental cost factors ratios improve, but still don't come anywhere near the 150,000 per QALY gained we'd want to see. So really the only thing that has an impact on this, because the utility estimates, we know that our point estimate and our ranges are encompassing whatever potential detriment for having TD or benefit for treating TD. It encompassed all of those values. The only real thing that can change the cost effectiveness of these drugs is a lower cost. That's pretty much, after doing all these analyses, what we came up with, which the companies didn't want to hear, surprisingly. TD, so this is just summarizing everything. TD is common among patients with antipsychotic medications. Just to give you some numbers, it's 30 to 50% of long-term users of first-generation antipsychotics will develop TD, at least mild, and many moderate to severe, and 10 to 15% of long-term second-generation users, a significant population. And given how these drugs are being used increasingly outside of schizophrenia, they're being used for depression, they're being used for bipolar, and now they're being used for anxiety conditions. It's concerning that we could be subjecting patients to this type of a problematic side effect. Valbenazine and deutetrabenazine have demonstrated clinical benefits and are likely to lead to improved quality of life in patients with these conditions. That part was shown in the clinical trials. They're approved by the FDA. We agree. These drugs could potentially benefit a number of people. The main issue is that we don't know what that quality of life gain is. And hopefully the companies are starting to take that seriously and undertaking these trials. But we don't have any information right now on what quality of life improvements patients would have with these drugs. The base case incremental cost effectiveness ratios for these two drugs far exceed commonly utilized cost effectiveness thresholds. The only thing that had an impact was reducing the cost by 90 to 95% of their current price. That brought them into cost beneath our thresholds for cost effectiveness. And all of our scenarios for hypothesized but unproven benefits did not result in them becoming cost effective alone. It might be that they could charge a higher price, like maybe $15,000 a year, if these benefits become proven and are not just hypothesized. But looking at just the hypothesized benefits, these drugs are still not cost effective. We had a number of limitations. The effectiveness of the treatment is based on limited intermediate measures from clinical trials, and that's always the case when you're evaluating brand new drugs. You have no experience with them. We're hypothesizing lifetime benefits. We don't know if there are lifetime benefits. The model applies to an average patient but may not reflect particular subpopulations. So it might be that for someone who can go back to work, had a high-paying job with depression maybe, it was treated with an antipsychotic, developed tardive dyskinesia, and was having difficulty maintaining their employment at that job. A subpopulation of patients might fit a profile like that, and a drug like this might be cost-effective in those individuals. So when we estimate cost effectiveness, it's on average for an entire population, not for individuals. And then the model results are sensitive to a few things. They're sensitive, but they didn't result in a change in the decision. And then for discussion, and I've mentioned this already, these VMAT2 inhibitors were priced as orphan drugs, then expanded to non-orphan conditions. So that's part of the issue here. They're being priced way outside of what they should be. There are no other FDA competitors, which means that although it's not a monopoly, it's a duopoly. There's two drugs in this marketplace, so there can be collusion. If neither of them agree to lower their price, then they both can make bigger profits from the same population. Few other therapies have clinical evidence. So even though there are no other FDA competitors, there are a few other therapies that are sometimes used for these conditions. The evidence for these is weak, and the risk to benefit ratios tend to be poor with all of them. So there really aren't other decent therapeutic options other than these drugs. The manufacturers were unwilling to alter their initial pricing, and this and possibly other analyses may provide negotiating power for insurers to obtain discounts. And that's why we do this type of work. Now, insurers can go back and say, well, give us a price of $10,000 and we'll consider covering it. And so without changing the list price from $55,000 a year, they can offer these deep discounts if they choose to insurers, and maybe they'll get coverage for the therapies. So these types of analyses give insurers some type of a cost threshold that they can use to try and get the prices to that, to at least closer towards that threshold. And then there's a lot that was not known. We had no information about the risk of longer-term use and possible dose escalation of TD-inducing medications. So one of the main discussion points was that, well, you don't have to switch patients off of this therapy that was effectively controlling the patient's schizophrenia when the TD developed from that drug. Now you can just treat the TD and keep them on this effective therapy. But we don't know what happens in that scenario. We don't know, does the TD get worse? Does it, are there other consequences to keeping patients on a therapy that's causing damage to dopamine receptors in the brain? But that was their suggestion for how it might, one of the suggestions for how it might benefit schizophrenia. The benefits of better controlled underlying mental health conditions, we don't really know about that, and the benefits of working, we don't know what those are as well. So with that, I'll take any questions you have. No questions?
Okay, so
yes.
I am still not convinced that the drugs even are effective.
No.
Can you go back to the slide? It might have been under your lit review where you looked at the CGI and was it AIMS score?
Yeah. Let me go. Where was that? It was right about here. There we go.
There. So,
yeah.
So I find this confusing. The AIMS score improved.
Yes. The AIMS score may be more sensitive than the global impression scale, which is why it shows some improvement.
Okay, so here's my fundamental problem with this.
Mm-hmm.
That's so elitist because the AIMS score is given by somebody observing.
Correct.
Theoretically a provider, right?
Right.
Okay. But I think, maybe I'm misunderstanding. It seems to me that they're really undervaluing the CGI. And that's a clinical global
impression scale.
Impression scale.
Yes.
And so, I mean, to say that one of those, there's a lot of space in between there, right? So the patient, if you ask the patient, they're saying they don't see any benefit. I guess what I'm getting at is a statistically significant difference in the AIMS, but is it clinically significant? I guess that's kind of what my question is. But I may be over-interpreting the CGI as
I mean, it could just
clinical.
We discussed this over and over again, and you know, with movement disorder specialists and with psychiatrists, trying to get a picture of what these were measuring and why there might be differences sometimes and not in other cases. Part of it was they standardized the way the AIMS was given in the clinical trials. They filmed patients, and then they had an impartial third person, not knowing what group someone was assigned to, evaluating the AIMS scale. And so that was better controlled than either of the global impression scales that they gave. For the patient ones, there was a lot of discussion around that, because if someone has schizophrenia, a lot of the patients who had TD had no idea they had TD or how severe it was or what was going on with it. And so a patient-evaluated scale is not going to show any improvement because they don't even know the conditions there. And it's pretty severe. It's obvious.
But then my question is, if the tree falls in the forest, does it make a noise? Because if the patient isn't aware of it, and it isn't bothering them, Well, it's like it's bothering everybody else, but it doesn't bother them.
Still not cost effective though.
But it's, I guess what I'm pointing out is that I don't
The
know.
drugs don't even work, or who cares?
Yeah.
Not at all. Like, does this
But-
drug work better in Huntington's chorea?
We didn't evaluate the literature, and I don't know. Yeah.
I hope it does.
My understanding is in Huntington's chorea, patients have even less awareness that the movement disorders exist.
Not early on,
No.
later on, but I
Yeah.
mean, that's my understanding.
Yeah.
Early on, I know.
Yeah. So yeah, there was a lot of comments around this part of it. And that's the difficult thing. We're doing everything on average, but just because on average some people don't know that they have the condition, the patients that I again showed at the beginning, those patients are very aware they have the condition. One was because of metoclopramide use. It wasn't an antipsychotic. She got metoclopramide in the emergency department, developed tardive dyskinesia, and it's with her for the rest of her life. And these patients were likely able to work and do things. So to develop a policy restricting patients like that from receiving therapy wouldn't make a lot of sense. So, I mean, we have to consider the patient populations and then you get into ethical issues. So should somebody with schizophrenia be denied the therapy because they're not aware they have the condition versus someone who is aware they have the condition getting the therapy? It brings up a lot of ethical questions.
Interesting. Thank you.